Hi everyone. Oh look, my glasses are crooked. Let's see, does that make it better? Okay. Hi, today's the 23rd of January 2018 in New Zealand, and I'm going to talk about the cascade of interventions, where that came from, what's it all about. It just feels funny all the time that I'm some old lady talking about childbirth. But when I gave birth in 1970, that was not a term that anybody used. There were standards of care, there were assessments, there was monitoring, and there were procedures. Those were all part of the evidence-based. I'm actually going to change my glasses because this is driving me a bit nuts. They were all part of the standards of care that were given to women at the time. So as I've mentioned, there have been 3 evidence-based practices since I gave birth in 1970 and 3 childbirth trends. So 1970, we went into the hospital in the United States, in New Zealand where I live now. A lot of women gave birth in the maternity homes, the hospitals. But we went in and we had certain things done to us. Those were standard procedures. Those were what was considered to be medically safeguarding the well-being of us and our babies, whether we liked them or not. And those things ranged from being shaved to having an enema to lying on our back during a contraction, having a vaginal exam, having people listen to the baby's heartbeat, staying in the hospital for a period of time, all sorts of things. There was just a lot of fiddling. But mostly in the 1970s, women were left alone to labor. In the United States, fathers came in with us. Pain relief was offered, but it wasn't imposed on us. We did have to stay in bed. We couldn't eat. We couldn't drink. It was 100% episiotomies. So there were just these things done. When I gave birth in 1982, we were in a whole new world. So there was a different evidence-based practice. Fathers were coming in. We could eat and drink. We could move around. There was early discharge from hospitals. There was breastfeeding. Babies weren't any longer taken into the nurseries. The monitoring had changed. You could now put a strap on a woman's belly before you had to listen with a stethoscope. You didn't get shaved. You didn't have an enema. There were so many changes, but there was still this evidence-based standards of care. So you were still left alone, and every 2 or 4 hours someone came in and took your blood pressure and your temperature, did a vaginal exam, checked the baby's heartbeat, and left you alone. And there was not as much episiotomies, but there were still episiotomies. There were forceps deliveries. There was now ventouses. The cesareans had changed from the 1970s, which was a classical incision up the uterus and up the belly that left ugly scars on women, to the low-lying bikini cut, because women were then wearing bikinis and they wanted not to have a scar, so the medical profession figured out how to do bikini cuts. Instead of being given a general anesthetic for a cesarean, you were now given a spinal, and then it became an epidural, and fathers weren't allowed in cesareans, and then they were allowed in cesareans. So really, there was just medical assessments, monitoring, procedures. But something shifted with the conversation that went along with the shift of the childbirth trend of the 1960s to the late 1970s in the United States, and from the 50s to the 70s in New Zealand. And that was that the new natural birth advocates started to advocate for choices for women, which was a good thing. Now, that came, as I've talked about in other of these talks, it came from the fact that Grantley Dick Reed, who is a male obstetrician, Lamaze, same, Bradley, same, all male obstetricians had developed these first skills-based systems that people took classes of, but those were directed and are still directed on women who want to achieve a natural or normal birth with less medical care and pain-free labors. So those systems, that skills-based system that was very limited to just a small group of people, hadn't achieved those three results. So birth advocates, the new wave of birth advocates in the late 70s then said, well, women should have choice. Now, what was interesting about that is, and this is where I keep saying that the first mistake was made in the 50s and 60s. If everybody had been told to be skilled, birth is an activity, all do it, all become skilled, everybody becomes skilled for birth, that would have been passed down now through the generations. But it wasn't. It was targeted to this natural, pain-free birth, normal labor. And that's sort of like if birth advocates had said only women who want a natural, pain-free, less medical birth, we're going to encourage choices for them. But in fact, in some ways they did, because the choice-based trend that we're in now is basically saying no to medical care and what you want. So let's take out the music and the incense and more people around you and baby to the breast and all the delayed cutting of cord, all that stuff. But everything was saying, no, I don't want to be induced. No, I don't want pain relief. No, I don't want augmentation. No, I don't want to have a standard episiotomy. No, I don't want to have vaginal exams. No, I don't want. So basically, the choice-based system was based on not wanting, choosing not to have the standards of care, the medical assessments, the monitoring of procedures. And this is where it's become complicated, because all of these things, whether it's stripping your membranes, whether it's breaking your water bag, whether it's having a fetal monitor, all of these things got lumped into this one phrase, cascade of interventions. It's sometimes too long to say medical assessments, medical monitoring, medical and procedures. We call them the AMPs. But the reality is when you lump everything into the word intervention, there are implications about that word. We intervene when there is a big problem, right? So in some ways, the cascade of interventions implies that every woman is going, and baby is going to die or be severely injured without it, that those are life-saving things, those cascade of interventions, and they sound scary. So if you have a problem, the medical profession is going to be the heroes. They're going to come in and rescue you, and you're going to have these interventions, and they're going to save you and your baby from death or serious injury. On the other hand, the other implication of the cascade of interventions, which is what's being used and what's implied, is that they are all unnecessary, they're all imposed on you, and this is the problem with the medical community, is that they're really out to intervene in your birth, disrupt what's happening, and they are imposing this on you, and you really need to say no to them, because if you say yes to one thing, you're going to get them all. And this is the myth, and this is crazy. Both. First of all, there's no cascade. It doesn't like tumble, and they're not interventions. Bad word, because the implication is either they're so necessary that the 30% plus cesarean rate now means that women are no longer able to birth, that babies and mothers would die without a cesarean, or that this is all being imposed on us. It's some sort of, I don't know, conspiracy theory that the medical profession is running around with a knife. They can't wait to cut us open because the insurance company and the money, and because they don't want to be sued, and all of that stuff. Whew, gets exhausting, doesn't it? So let's talk about these assessments, monitoring procedures. We are in a choice-based trend at the present time. However, if you're going to go to the hospital and you go to a doctor, you go to a midwife, they are going to do assessments, they are going to monitor you, and they will do some procedures. And it depends on what you define of as a procedure. And for women, what are you uncomfortable with? I don't know what you're uncomfortable with. Some women feel having their blood drawn is a procedure, and they're uncomfortable with that. So let's talk about the big ones, the induction of labor. So that can be a stripping of the membrane, it can be rupturing the water bag, it can be putting a vaginal suppository in you, it can be putting an IV in with a hormone that stimulates your labor. So that is a procedure. No matter how you call it, it's a procedure. And you will be monitored because they know it's a procedure that disrupts things, so they want to make certain your baby's okay. So it went from listening to the heartbeat with a stethoscope or Pinard, which was that long wooden thing, to listening with a fetal monitor or a Doptone. So you're going to be monitored as well. So is an induction of labor something that's wrong or bad? Well, that does depend on you. So they now have, the medical profession now has a definition based on research, good or bad, right or wrong, that if women go past 42 weeks of labor, that there is a greater, how do we know if it's a significantly greater risk that the placenta is going to be deteriorating and that your baby is at higher risk of having a problem? Is this real? No, it is real because they've done statistics about it. So the medical profession that is based very much on research is doing research and saying, yes, this is a potential. However, if you go to 42 weeks, you don't know whether you're going to fall into that statistic, which means that you should have a choice. Do you want to be induced at 42 weeks or earlier for some other reason, or do you want to say no? However, whichever way you go, if you say, yes, I want to be induced, you have to live with the consequences of that choice. If you say no, you have to live with the consequences of that choice. And that's what's so important around understanding medical care and saying yes or no to it. There is no cascade of interventions. There are a series of interventions that make sense based on maternity care. You can say no to them. You can say yes to them. Whichever way, you have to live with the consequences of it. So if you choose to be induced, how long does it take? Well, if you strip your membranes, it takes, 30 seconds? I don't know, a minute? Okay, well, get on with the birth. If they rupture your water bag, maybe 5 minutes with fiddle, 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 and then they go in with a long crochet hook and go pop, and it ruptures. Okay. So if you have a suppository in, it may be in for a while. If you have a drip, it may be in for a while. And this is why birthing better skills are so important, because the reality is if you lack skills, then right away you feel, oh my God, something's happened to me. But if you have skills, you just say, oh, well, that was a procedure, it was done, and I'm just going to get on with birthing my baby, and you get on with it. So let's now talk about augmentation. That's if your labor is slow, if you're just pausing, you haven't gotten past 2 centimeters, 3 centimeters, 5 centimeters. So then they say, well, we need to get your labor going. Why do they want to get your labor going? Because they know that if labor goes on and on and on and on, which it used to do when I gave birth in 1970, the cesarean rate was 3%. They let women go on and on and on and on, and they really didn't have any ways to augment labor at that point. And if they did, it was an intermuscular shot that just drove your labor into hyperdrive, which was really irritating. We understand that, but the medical profession's come a long way. However, so has women, because women don't want to suffer in birth. And the term suffering in birth doesn't have to do with whether there's a problem. It had to do with women not coping well with the natural occurring pain of labor, and it going on and on and on and on. And there is a greater risk to the mother and baby if labor goes on and on and on. Well, what's on and on and on mean? Well, in the reality, if a woman gives labors and gives birth within from 4 hours to 15 hours, that's reasonable. Anybody can really do that work. If it gets shorter than 4 hours, it's sometimes too intense. If it gets longer than 15 hours of labor, not just niggly-nigglies, then women get tired. And if it niggly-nigglies for 24, 36, 48, 72 hours, women and babies become exhausted. And they become at higher risk. The baby becomes higher risk at being depressed at birth, and a woman is at higher risk of having a postpartum hemorrhage. So the augmentation of labor was based on the fact that you want women to move along and you want the baby to be born in a reasonable amount of time. And this is where skills come in. Because if you've prepared your body to open up to let your baby out and know how to keep your body mobile and keep soft inside, and you work effectively with the contractions, and you get into positions that you can tell from reading the contraction that the contractions have a bell-shaped curve rather than flatten out, then you will choose positions that keep that bell-shaped curve, which will tells you your baby likes the position you're in, that you're not compressing its space, and you don't have any internal hidden tensions that's stopping the baby from opening you up, coming down through and out. And when that occurs, your labor will be progressive because your baby is showing you that how your position or posture is permitting them to open you up and come down through and out. So skills were really essential. Skills reduce hugely ineffective labors. They reduce ineffective second stages hugely. If you've prepared the inside of your birth canal, not just the perineal massage, if you've gone into every muscle from around your sit bone, the muscles between your sit bone and your sacrum, and you go into the wall of your uterus and all the muscles around your rectum, as well as that ring, then your tissue, soft tissue, will open up like a lotus to your baby coming down. And obviously second stage becomes shorter. So the augmentation, this intervention, but it's a procedure, it's an augmentation, is done because we lack skills to have effective births. If we have a big baby and our labor's slower, if we know how to open our body, we're more likely to do that. And if we know how to check ourselves, you can go in with, as a woman, you go in with your middle finger and you feel the pubic arch, and you go up where you pee, and then you run up the pubic arch and you can feel how much of a curve of your baby's head is in your vagina. If there's not much of a curve, you can feel the baby's head above the pubic bone. If there's a lot of a curve, you can't feel the baby's head above the pubic bone, and your baby, the broadest part of your baby's through the narrowest part of your pelvis. So augmentation is done to try to get your labor going. Forceps, ventouses are done because you have a tight crotch. So we have a responsibility as women now to change the conversation around childbirth. We have been in a skills-based trend. We have been in a choice-based trend since the late 1970s. It isn't working. If you don't want to be induced, don't be. That's fine. If you don't want to be augmented, don't be. If you don't want pain relief, don't have it. But what we're saying is become skilled. Know why you don't want those things and have the skills to cope and manage. If you don't want to be induced at 42 weeks, you've got to live with the consequences one way or the other. You always have the right to say no to any type of medical care. It's harder to say no when you're feeling overwhelmed. And so if you don't want any of this stuff, then your behavior, the way that people see you in birth, is going to determine what they offer you. So if you look like you're coping and managing beautifully, they're not going to offer you pain relief. It's simple. If you're looking overwhelmed and you're sweating and you're hot and you're bothered and you're bitching at everybody, of course they're going to offer you pain relief because they don't want you to suffer. They think that offering these things to you will leave you with better memories about your birth. And instead, because women are choosing not to have things and then end up with these assessment, monitoring, and procedures, more women are ending up with TABs, trauma after birth, because they had things done to them that they were saying they didn't want beforehand or even at the time. But you have to realize that the medical profession is there to help you. And if you are behaving as though you're injured or unhappy, they really want to help you, right? So part of our responsibility is we have to behave better. And the only way we can behave better, and behave isn't be a good little girl. Behave better means that we skillfully know how to birth our baby. We cope. we manage, we work through, we deal with, we stay on top of, and we stay in control of how we respond to the internal sensations and how we work with the medical care that is given to us. Now, how can you help us? Share this video, for goodness sakes. Share the YouTube videos and the playlists of Debunking the Myths. Purchase the Birthing Better resources and help our trust continue to grow, or else just give us a donation, for goodness sake. Our PayPal is info@birthingbetter.com. Spread the word. Tell people. Become skilled. If you want to say no to medical care, then show people that you can work through your birth in dignity with skills. And if you get more medical care than you want, that's the way it is. Use your skills, because skilled birthing families just really say, well, that's what they're doing, whatever. I mean, I'm going past 20 minutes, so I worked with a woman way back in the early 1970s. She and her husband were one of the families that developed the skills. She wanted a vaginal birth after a cesarean, after a classical cesarean. She went around to every doctor in the community, and they all said no. But an osteopath who had hospital privileges said yes. And he basically said to her, I want an IV in you right away. And you can't eat, you can't drink, you can't get out of bed. So she agreed to that because he was going to let her do a trial of labor. She negotiated that they would put an IV in, and she was a nurse, that they would put the IV in when she started to push. They let her squat on the bed. She worked beautifully through the birth. They really admired her. And then when he checked her and said, okay, you're fully dilated, we want the IV in, they couldn't get their line in. 6 times on this arm, 6 times on this arm. They had everybody in the hospital trying to get an IV in. He was insistent they get an IV in. That woman never skipped a beat. She continued to use her skills. She went limp in her arm. She let them do what they felt they needed to do, because she knew that if she used the skills, she would just cope better. She didn't freak out. She didn't argue with them. She didn't do anything. So when Birthing Better families go into hospitals where more stuff is done to them than they would have liked, you know what they do? They get on with their birth. And they just go, that's what they want to do. I chose to come to the hospital. I'm living with the consequences of this. It isn't that bad. I'm just going to get on with it. Get on with it. And that's what we did. So is there a cascade of interventions? No. There is medical assessments, medical monitoring, and procedures. And if you have every single one of them, that does not stop you from using good skills. What stops you from using skills is that you didn't learn them and you're not using them. So let's grow a skilled birthing population alongside choices, and know that if your choices unfold, skills will enrich your birth. And if your choices don't unfold, skills are the foundation of your behavior. So see you tomorrow. More to go. Would you ever believe?